great to be here today. Good morning, everybody. My schedule has been a little up and down. I was supposed to be in Albany, and then I was supposed to be at another event, but I told my team I needed to be here. I missed this last year, to my regret, and I'm so glad to be here today. Thank you to Michael, thank you to Chetan, thank you to everyone at Northwell for having us here today. You've really been leaders on this issue, and it's so important to watch our health system step up as a part of our wider public health system. I'm certainly honored to be here today also to host this distinguished panel on the intersection of behavioral health and gun violence, behavioral health being really a centerpiece of our public health work here in New York City. As what's called the city's doctor, I'm tasked with leading a public health system with the goal of protecting and promoting the health of 8.5 million people. But I'm also here as a person with lived family experience. I was 10 years old when my uncle committed suicide. 25 years later, I found out actually that it was death by suicide. Such was the level of stigma in my own immigrant family around mental health needs. And as you all know here, gun violence is much more than an individual or family issue. It has community and ripple effects that impact population health and population mental health, and that require public health strategies to interrupt these cycles and these ripples. That's why here in New York City, we've centered violence prevention, and specifically gun violence prevention, in our population health and mental health strategy for our city called Healthy NYC, aimed at increasing life expectancy in New York City to its highest ever level, 83 years, by 2030. To do so, we will have to address the leading causes of death and premature death. And as you might imagine, gun-related violence, gun-related self-inflicted violence, suicide, are key. We've set out a very clear, measurable target to reduce both death by suicide and death by interpersonal violence, most of which involves guns in this city, by 10% each by 2030. And we're marshaling a whole of government response to get there. So this isn't just one agency or one part of government. In fact, it's not even just a government effort. It's every part of our civic infrastructure coming together to meet these goals. Public, private, nonprofit, philanthropic, community, faith-based organizations aligning themselves behind this campaign. Underneath this includes our blueprint for community safety and our mental health agenda, Care, Community, and Action, which was released last year, both released last year, and which invests over $500 million in a range of upstream and downstream interventions to break cycles of violence and reduce risk and exposure to guns using a public health approach. This includes many investments into addressing the intersections between mental health and gun violence, including over $100 million for community-based trauma-informed care and bolstering mental health resources for young people, along with peer-led and community-led crisis response services, really focusing on the places and the neighborhoods that are most impacted by guns. It means expanding our hospital-based and community-based violence interruption work and enhancing community training on conflict mediation and navigation to mental health support. For teens, it also includes NYC Teen Space, our effort to make digital mental health support with a licensed therapist available for free in the palm of your hand to over 400,000 New Yorkers aged 13 to 17, so that they can normalize asking for help and getting it on demand. And lastly, it also means our leading work on tackling social media's role as a public health threat in worsening youth mental health and in perpetuating gun violence as a conduit for bullying, harassment, and violent language that all too often results in violent actions involving a gun. Let's be clear before we start a panel on mental health and gun violence, we all know that mental health does not explain our epidemic of gun violence in this country. Independent of mental health or substance use, guns are a risk of death and premature death, full stop. We also know that people living with mental health issues are far more likely to be victims of gun violence than perpetrators. But we cannot ignore the links between gun violence, including mass shootings, with risk factors such as domestic and family violence, trauma and sexual abuse, and alcohol and drug use, all risks that worsen mental health and lead to chronic mental illness. Which is why I'm honored to be here today to moderate a panel of distinguished experts working at the intersection of behavioral health and gun violence prevention. So let me introduce them now. First, we have Michelle Hillman again, Chief Campaign Development Officer at the Ad Council. Michelle has led massive award-winning national campaigns, including the Real Deal on Fentanyl, the COVID-19 Vaccine Education Initiative, and obviously just had a fancy, awesome new gun violence prevention announcement minutes ago. Next is David Mohammed, Executive Director of the National Institute for Criminal Justice Reform, where he authored the seminal report, A Positive Youth Justice System, and has worked to reform probation and justice systems across the nation. And Kim Smith, Director of Programs at the University of Chicago Crime Lab, where she leads a range of research in government and with government and nonprofit agencies, including the development of the Chicago Violence Reduction Dashboard. Thank you. Okay, so let's get started, and let's get started by having you offer up your thoughts and perspectives on this intersection of behavioral health, mental health, and gun violence prevention. All too often we see it used as a red herring for inaction or a distraction. And so tell us your perspective, and if you can weave in a little bit about your work in the process of telling that story, that'd be great. Maybe Kim, you could start?
Sure. Well, thank you, Northwell, for inviting the Crime Lab back to this forum. It's really important to see and to know that the hospital systems around the country are very active in this issue. So briefly, the University of Chicago Crime Lab, where I work, is a nonprofit, nonpartisan research center based at the Harris School of Public Policy, and we partner with public sector and nonprofit organizations to identify, test, and scale effective solutions to both our country's gun violence crisis and a criminal justice system that is not truly just. We have been able to partner with incredible nonprofit organizations, some of which are represented in the room. I think I see Not Another Child and Life Camp in the back. And our theory of change really rests on the idea that the public sector is where you can have impact at scale on both of these challenges. However, what has not been the case historically, it's starting to change, is a robust body of evidence about programs that work, largely because of a lack of funding. So partnering with nonprofit organizations, leveraging philanthropic support, and then working with the public sector to scale effective solutions, we think, is one of the ways in which we can make significant progress. And much of our work actually is quite intersectional with respect to the different types of agencies and even the data sets that we look at in order to understand impact. So it's been really heartening to hear some of the initiatives that are underway in New York, and the kind of intersection between behavioral health and gun violence is really apparent. One statistic that we often talk about is the impact that exposure to gun violence has on the very root causes that lead to gun violence. So Pat Sharkey, he's a sociologist at Princeton University, has done work quantifying the impact that exposure to homicides have on young people in Chicago. If you are a student, you live on a block where a homicide has taken place, in the week following that incident, you will test as if you have missed 2 years of school. We know education is itself incredibly protective against future gun violence involvement. So even just thinking about the behavioral health impacts that gun violence has on root causes, I think is really important.
Yeah, I want to come back to this because I think what you're doing is so important to lift up the role of data and evaluation, but I want to get your take on how to bring that into the decision-making context, because in my seat, I often see these, we're awash in data, and we're even, we have a lot of insight, but decision-making comes down to a lot of other factors, and so I want to understand your take on this. But David, you've worked your whole career to reform probation systems and justice systems around this country, working on the ground with officers and young people, including your work today with LA County, which is the largest probation system in the country. Tell us your perspective on this intersection between mental health, behavioral health, and gun violence, and particularly from the perspective of youth, and intervening early so that these don't land in long-term chronic mental health issues.
Yeah, that question. I mean, we have
big
like
question.
An hour to answer that.
5 minutes.
So, I mean, a couple things. The National Institute for Criminal Justice Reform, we're based in Oakland, California, but we work throughout the country, and both on justice reform issues, but also on violence reduction strategies. And for years, I was either one or the other. And more, thankfully, there is some coming together of those issues because, as there should, when I was the head of adult probation in this city, we had an initiative trying to identify the top 100 people at highest risk in each borough, top 50 in Staten Island, and to look at what are the common risk factors that make someone likely to be involved in gun violence. And I think one of the, I think you said it at the top, we use mental health as a excuse and a denier to focus on what we need to focus on. But there is this issue of exposure to gun violence, there's an issue of trauma. And so what we've experienced is when you have community dynamics of concentrated poverty and low-performing schools and historic disinvestment, the proliferation of liquor stores, guns easily accessible, drugs easily accessible, this deadly mix. But even in the most challenging neighborhoods, we're in New York, so if you take Brownsville, Brooklyn, the most violent, the neighborhood with the highest rates of violence, language is important, the vast majority of people in that neighborhood are not involved in gun violence, right? So it's important to understand that. So there are a small number of individuals, and there's public health approaches, right? So that's been around forever, but we learned during COVID, one, contact tracing. So when somebody is involved in violence, they have a network around them, right, that have a heightened risk of being involved in gun violence when their person, fellow group member, friend, family member has been involved in violence, right? This issue of it being a communicable disease, and this issue of informing people of their risk. We knew during COVID somebody's over the age of 65 or they have an underlying health condition. We need to inform them that if they contract the COVID virus, they have an exponentially greater risk of having serious illness. There's a small number of individuals who have a series of risk factors that are identifiable. So the people are identifiable, the violence is predictable, and therefore it is preventable with effective intensive intervention. And we need to inform those individuals of their risk and have them make better decisions based upon this risk. And last point on this is, the other thing around this is understanding what we're trying to achieve by what time frame. If we want to change neighborhoods so that Brownsville, New York, right, has much greater resources, much better opportunity, that is what we need to do. That's a long-term process. We need to work on that. But if we want to stop the shooting from happening tomorrow, next week, next month, that is specificity and intensity, specifically working with the people at the very highest risk and doing so in an intensive way. So this notion of community violence intervention, CVI, is very specifically focusing on very high risk individuals with people who have similar lived experiences, who can relate, have credibility, hence credible messenger, but they're also engaging this person intensively, every single day engaged with this person. And that is different than your normal community-based organization, community service. And so we need to understand the difference between prevention and youth development and reentry and CVI. All important, all valuable, yet different.
And apologies, I forgot that you were here, and we're going to claim you. We're not going to give you over to California. You're a New Yorker. Michelle, you've just been here talking about the exciting new campaign that you're launching on gun violence prevention. And independent of that, the Ad Council has launched plenty of campaigns on substance use disorder and mental health issues, youth mental health issues. How do you start to think about storytelling in bringing those narratives together and really making people, especially young people, see the links and see mental health resources as an off-ramp from another set of choices? Tell us how you think the Ad Council can help and how you plan to bring weave mental health into this exciting new campaign.
Yeah, great question. So, at the Ad Council, we've been really entrenched in what we call the crisis of humanity that has really escalated coming out of COVID, right? Like, and you talk about it, we're focused very deeply on 4 pillar areas. One, mental health, talking to youth, adults, veterans, really specifically with resources for them. We're very entrenched in the opioid crisis, talking to parents and youth about fentanyl, bringing fentanyl awareness into the scene, substance use, how to get people on the path to treatment and recovery, and hate and bias, which you mentioned in your remarks. And when all of those things do converge with guns and gun violence, then a moment of crisis really can turn into a tragedy. And so while we have discrete efforts in all of those areas, we do really look for intersection points. We work very closely with the mental health community, many partners that are in this room and others, on helping us form and develop all of that work and making sure that we have resources that really honor all of those things and that we're not doing harm when we're talking about one issue versus the other issue. We've spent a lot of our time on gun violence so far, as I mentioned, really in the space of safe storage, and now moving into where Amy had talked about earlier, the emergency restraining protection orders, because what we found in our work, where we're not going to get into the politics because that's not what we do, but putting time and space between a moment of crisis and access to a gun is really how we're going to help save lives. So we've spent a lot of time in the last year really doubling down on emergency restraining protection orders. When the Bipartisan Community Act was passed, we saw a need to provide greater clarity for the general public and law enforcement around raising awareness on the law, really digging in deep in a research project that we did with the Joyce Foundation. And thank you to Tim Daly for supporting us to really understand, what do people know about the law? Do people support it? What do they need to know? What can we call the law? How do we sort of take a disjointed communication strategy and do our part while the states are bringing together all the collaboration that Amy talked about earlier? So the good news is, we did a lot of research. We brought local, state, federal, government, law enforcement, the health community along the way through a series of webinars. I know I talked to some people here today that participated to share our findings, to get input from them. We've published a public-facing toolkit that really will help unify and amplify communications around that as a tool. And just quickly, some of the highlights from the research that I think are relevant here. There really is common ground that we see when we're talking about gun violence and some of these tools to really help people in a moment of crisis, right? So we saw people, 78% of the country tell us that they believe in this as a tool to help put a moment of time and space to push pause when someone's experiencing a crisis. If there's a domestic violence situation, 86% of the people that we surveyed agreed that this was the right thing to do. And what we heard people saying is, tell us more. How does this work? Is it temporary? What does it mean when someone's in a crisis? How can we, and I think this is work we'll continue to do as we look at the intersection, how do we help people identify, what does a crisis look like? When does a crisis become a moment where we need to have an intervention of a close friend, a family, a loved one who may enact an ERPO or bring more safe storage solutions into a home to help us mitigate, an overall crisis. So we're doing some work right now on a national campaign with Brady. We're doing a test pilot in Illinois on a new campaign around the pause. And the hope is that it's turnkey so that all the other states, as they're working with Department of Justice, can come in on that as well so that we can sort of bring those conversations together in the way that would help.
Yeah, thank you. And it's a great segue. You mentioned some of the broad-based data you're finding through qualitative research. What are you seeing in the data at this intersection that offers you inroads into policymakers' brains and decision-making processes? And when you're structuring the questions that are most interesting to you, how closely are you working with elected leaders, people in positions like mine, to make sure that you're answering the questions that have the highest likelihood of action, subsequent action, regardless of the results, that have the highest likelihood of subsequent action in this intersection particularly?
So I like to say, we're not normal researchers, we're cool researchers in that our work is intended to be, yeah, we're cool nerds.
Missed that cool research.
We want our work to be applied. If it's just, us writing a paper for the sake of publishing in a fancy journal, that's not having impact at scale. So much of the work, the vast majority of our projects are actually co-designed and co-created, not just with policymakers, but with nonprofit organizations. organizations. There's not a dearth of amazing work happening. What there is a dearth of is a solid understanding of which programs work for whom and why. So as an example, in 2015, Chicago was experiencing an increase in gun violence among school-aged youth. And at the time, there was a dearth of programming for young people who were beginning to disconnect from school. We held a design competition, really trying to understand what's already happening and how does that relate to what we're seeing in some of the narrative data from the Chicago Police Department about the kind of proximate causes of gun violence. And I do think this is a really important point, so I'm going to spend a bit of time here. Oftentimes when we have conversations in Chicago and elsewhere, people assume that shootings, firearm injury is the result of intentional, especially in the community context, intentional planning. It's, what you see in The Wire, fights over drug turf, I want to advance the goals of my gang or my clique. And that is sometimes the case, but the vast majority of those incidents actually stem from altercations which turn deadly because a gun is at hand. So one thing that we've seen over time in many different contexts is that programs that incorporate cognitive behavioral interventions or therapy really encourage folks to slow down their thinking and deploy a different set of decision-making tools in high-stakes situations. Those can be really effective. So at the time, one of the programs that we received a letter from was a program called Choose to Change. We've evaluated that program. It's a 6-month intensive program, combines really intensive advocacy, mentoring with group-based trauma-informed cognitive behavioral interventions, and we found it to be effective. 45% reduction in violent crime rearrest, 32% reduction in school misconduct. The public sector was at the table, and they have since taken that body of research and scaled it. So we have a number of different organizations now delivering that program. There's a playbook that's available, and that is really the goal, is for the public sector to come to us with the challenge, to be at the table, and then to take, be the consumer of evidence and scale it up.
Yeah, it's the best kind of partnerships.
It doesn't always work that way.
It doesn't always work, but it's the right intent.
Yeah.
So I'm going to ask, we have a few minutes left. I want to ask all of you the same question, and I'll start with you, David. So here in New York City, as you're seeing in jurisdictions across the country and you're seeing coming out of the federal government, the interest in and frankly the concern expressed around the intersection of social media and youth mental health. We here in New York have declared it a public health crisis very intentionally, because not only are we seeing profound jumps in the data around the use of social media and its impacts on anxiety, depression, loneliness, isolation, self-harm, thoughts of self-harm. But we're also, in a very troubling way, seeing social media platforms being used as the conduit to perpetuate gun violence. When I spend time with our community violence interrupters, you can trace you talked about contact tracing. Well, contact tracing is often done person to person, but now it's being done video to video. And you can see one YouTube video and then another posted in response and then another posted in response, each escalating until an actual physical act of violence happens. And so I would love all three of your perspectives. I know that social media is ubiquitous. No one is saying getting rid of social media. I think that's an impossibility. Harm reduction is certainly a core public health principle, but we have to bring some sense to this currently unregulated sector. How do you see gun violence and the kind of secondary effects, the contagion effects, as I'd like to say from a public health perspective, how do you see that playing a role in telling the story about the kind of guardrails we need? And it comes at a very specific time, right? The Supreme Court right now is looking at this First Amendment case, which is going to make a big difference on what content moderation is able to do. So David, maybe David, Michelle, and then Kim can end.
So, I mean, one, the issue of social contagion, right, which was the name of a study in Chicago that, to this point, I was making earlier around when a pretty powerful study that had looked at people that had been arrested together previously, and that when one of them was shot or arrested for a shooting, the other had an exponentially greater likelihood of being shot or arrested for a shooting in the next 18 months. So this notion of social contagion. I could make the argument that social media is the largest contributor to gun violence in the country. Now, it's deeper than that, and it's more nuanced than that, but that argument can be made that so many incidents are on social media and escalate to real-life gun violence. There's a crime analyst in the police department in Washington, D.C., in one division that looked at 6 of these battle rap social media videos that contributed directly to 10 shootings in a very short period of time. And that type of data, that type of immediate intervention that we need, but also understanding who are, because everybody who's involved in some sort of back and forth on social media, that happens all the time, right? Everybody's not resorting to gun violence around that. So it's still not just the social media, although that's important, but it's also understanding who are the individuals that have the series of risk factors that make it likely that they're going to try to resolve conflict with a gun, and that is the type of data that we have access to, that we need to have a better job at that. We need to do a better job sharing that, coordinating around that, and having the type of specific and intensive intervention with these individuals. Very, very quickly, because you asked about youth, 2 quick points. One is we have to have 2 things in our head. The number of young people involved in gun violence is increasing, and it's a crisis, while adults are the vast majority of people involved in gun violence. Vast majority of people in gun. There's hardly any city in the country where more than 12% of victims or suspects are juveniles. So we have to have both things in our head, right? That it is primarily an adult issue. Young adult, right? But primarily an adult issue. The average age of a homicide suspect in most cities are about 25 to 28. Right? While simultaneously, way too many young people have guns, there's way too many juvenile violence. So we have to have both realities in our head. And those young people, last point, it's a small number. And so in DC, we're doing the study, 50 adults are convicted of homicides. We're able, a court order has given us all their data going back to 10 years old. Child welfare, juvenile justice, school stuff, behavioral issues, to say, is there a discernible pattern of risk factors that makes this young person distinguishable even from the other at-risk young person, to say it's likely in 10 years they're going to be involved in gun violence. So that's, then the second one is, can we track that real time? So when at 11 years old, Johnny hits risk factor number 10, he glows bright pink and mentors fall from the sky. But some sort of intensive intervention when this young person has the series of risk factors. And last point is, for instance, in DC, there was this detailed study of young people who had been involved in gun violence, teenagers, and many of them had 25 child welfare investigations by the time they're at 14 years old, right? And there was 0 intensive intervention done with this family. Right? We could see this train wreck happening from a mile away and no one derailed the train, right? And so we have to do better at caring about these families and seeing this happening and having an intensive intervention.
So I know we're getting towards the end. Kim, I'll actually just give you the last word on this issue of social media and youth mental health and gun violence, that intersection.
I think social media actually has a role to play, not just in mitigating the harms, but also in identifying solutions. So I talked about some of the research that we and others have done that shows that things like cognitive behavioral interventions can be really helpful. The question is, how do you scale that? So we've done it in Chicago with 600 young people. How do you scale that to 10,000, 60,000? Across the country? Are there different modalities that might be effective? How do you personalize it in a way where you don't lose fidelities? And some of these questions feel, ripe for folks like Meta or, other companies to help us interrogate. And I would like to think that in addition to kind of identifying those solutions, things like pushing out different norms, there's work being done by Chicago Cred to use different social media platforms to change the norms around, how do you engage in conflict. So I would like to, leave us on that hopeful note. Obviously, still a lot of work to do, but there are a lot of questions that I think social media companies could actually be really helpful with.
Thank you. That's a great way to end on a hopeful note. What a great panel. Let's give it up for them.
Yeah.